Hi, I'm Scott Swanson. I'm a thoracic surgeon at the Brigham and Women's Hospital in Boston, and we're here with a panel of colleagues to discuss minimally invasive lung surgery. And over the next 20 minutes, we hope to discuss the relevant issues in minimally invasive lung surgery and the advantages and disadvantages of the various techniques. Hopefully we'll answer any questions people have out there in the audience about when to use these techniques.
Hi, my name is John Wee. I'm also from the Brigham and Women's Hospital.
Hi, I'm Robert Cerfolio. I'm sorry to disappoint you. I'm not from the Brigham and Women's Hospital, but I'm from University of Alabama at Birmingham.
I'm Dan Miller. Hello. And I'm from Emory University in Atlanta, Georgia.
Hi, my name is Bernie Park. I'm from Hackensack University Medical Center in Hackensack, New Jersey.
I think one of the things we're going to try to cover is the fact that we have essentially two techniques for taking parts of the lung out minimally invasively, either a video-assisted technique or robotic technique. Some of us in this panel are old enough to know and been there when the VATS began, and robotics is a newer technology, and so we're going to talk about the various options that one has. I am a believer in the VATS approach, and I think some of our members are more robotically oriented and others are kind of in between. And I guess what I would throw out to the panel to begin with is what are the advantages of minimally invasive over open, and in one or two or three bullet points, and then for those issues, which is better, VATS or robotics?
Sure. So I'm happy to take a swing at the first one. I mean, I think, the data has been clear over the years. I was the biggest basher of minimally invasive surgery out there because I felt like the lymph node dissection wasn't great. However, the data is very clear that you have less pain, less length of stay, less morbidity, and pain and length of stay is in the eye of the beholder. But less morbidity, less respiratory complications, which have been shown again and again and again by you guys with video-assisted techniques, is clear to me now. And so a minimally invasive platform is what we should be doing. And really, it's us against stereotactic radiosurgery, to be honest. We're happy to discuss VATS versus robotic, but really the debate is about minimally invasive surgery versus stereotactic radiosurgery. Having said that, I went from open to robotics. I just was unhappy with the lymph node dissection with that, and that may be my own inadequacies as opposed to the technique and the platform itself, because clearly in experienced hands it's good. But I'll be more argumentative than that and say in the typical general thoracic surgeon's hands, I think the average general thoracic surgeon can do a better lymph node dissection with a robotic platform than they can with a VATS platform, although in expert hands, probably it's a wash.
Yeah, I had a slightly different, approach to minimally invasive versus open. I was really trained to do everything open, and really had to then sort of teach myself minimally invasive techniques, and I was able to not only train doing VATS lobectomy, but also in parallel trying to do robotic lung resection. And I personally consider the two techniques really to be really very close cousins. I don't think it's a real difference between VATS and robotic. I think robotic is just the most technologically advanced form of video-assisted thoracic surgery. And the area, clearly we did a lot of research, and the panelists have shown that, again, as Surf mentioned, that minimally invasive approaches are beneficial, proven to have quicker recovery, less complications. And the real issue then becomes, what's the role of robotics? Why should somebody do robotics versus VATS? And I think the point's already been mentioned that if you have experts in VATS and experts in robotics, the outcomes in the OR and for the patient are going to be very similar. But the question is whether robotics overall makes the average thoracic surgeon more accessible to minimally invasive techniques than the VATS platform. And the one thing I'll say is that with what I found in doing both techniques parallel was that robotics allowed me to replicate minimally invasively better what I was trained to do as an open surgeon. And so that's one of the reasons that I persisted. I was doing it in 2002 before anybody really was doing it to any great degree. And And it was because of those perceived advantages to me as a surgeon that I continue to do it, currently, even though it's still not a widely, utilized technique.
Let's get Miller in there.
Yeah.
Well, I'd like to disagree.
You would?
To a degree, because first of all, we're all tactile surgeons. That's how we learn from the open technique, and so forth. So to go from that to completely non-tactile is what robotic surgery is. Whereas for VATS, it was a natural progression. We use the same instruments as we did for the open cases. And so for me, it was a natural progression to go from totally open at Mayo, which we were trained, and that's the only thing they do. And then to VATS, it just made more sense. And for me, it was an easier progression, and from cost and utilization getting to the OR, it was easier for us to do that. And so I know that some places, if there is a robot there and there's time to use that, then that's something to look at. But I think you said for the average thoracic surgeon, I wouldn't disagree and say thoracoscopically, since that's been around for about 20 years, it would be a better adaptation of that technique to go to that next level.
So
How about we? Let's get we in here, because he does both.
I've done both. I probably practice about 50% doing VATS lobectomy, 50% doing robot. Partly because of availability of the robot, usually, but if it's not available, I don't necessarily fight for it. I think there are certainly advantages to robotic visualizations, but I also find the robotic limiting in a lot of ways. The patient's fixed, and if you find something in the chest that you weren't expecting, it's hard to maneuver the patient around to get the same kind of visualization I can do with the VATS. I can change my camera around, angle around, and to me, that flexibility is helpful in a lot of cases. I do agree that robotics is technically advanced in terms of technology, but I think in terms of real, medical value, it's limited depending on what your skill level is. Now, we know that really only 30% of lobectomies are done invasively anyway, and robotics may improve that number if some patients who can't, or some physicians who can't really transition to the VATS can transition to the robot. But there's a lot of things besides just the robotic technique that really you have to learn in addition to just going from VATS, because how the room's set up, how you operate with the lens and the camera is different when you go from an open to a VATS technique, and I think that transition is easier when you go to a robotic technique than it is a VATS. But you have to be aware it's not just the instrumentation that you have to learn about, it's really the whole setup, and that learning curve, it's much steeper if you've never gone through VATS. If you've never transitioned to VATS, doing VATS lobectomies, doing that transition from open to robotic technique is a much steeper curve that I don't think is as appreciated.
So let's throw out one other question.
Can I disagree with that statement?
Sure.
Go ahead. But I disagree with the statement about the learning curve, but go ahead.
So I think we're all saying efficacy is similar. The lymph node thing we can debate. I take a little different tact, and the data would suggest VATS lobectomies don't have a worse node dissection outcome other than a couple of small series. It's either the same or better than open. So it's hard to believe robotic will beat them both, but maybe, we'll see. But the question I would have is around safety, because I think cost and safety probably are going to be ultimately what trumps this discussion down the road. And I would like to hear everyone's input on the safety question around who's at the table, who's at the console, what do you do if there's a problem, are there certain cases you really have to worry about, because I did some robotics in the mid-2000s, I'm looking at it again, and that's one thing that strikes me, is you do not have the same control level, and if you do have that kind of control level, you may be paying for it with some really experienced FTEs.
Well, so I think safety, I've done over 700 robotic operations now, and it's nothing to do with where you are. You can be in Idaho, whether you're at the table or you're at the console. I think the safety issue is the same. I think the robotic zealots are going to tell you that the injuries during VATS, because VATS is more of a sweeping, are worse injuries than robotics. I don't know if there's data for that, but no one's had more holes in arteries or veins than me, and every single patient, except for one, every patient you can just put pressure on it, hold that pressure. We're doing our cases with no type and cross, no type and screen. We get blood ready, we wait 10 minutes, and then I go up and open electively. And that's what I would do when I was doing VATS. I think to immediately open after an injury is a big mistake. You're not mentally ready, you're not physically ready, anesthesia's not ready. It turns into a flail. You should pack, hold, pressure, and weight, and you can do that from the console as well as from the table. And in terms of FTEs, I have a nurse at my table. All of our cases have been done with a nurse. There's no 2 doctors. When I have a fellow, the fellow's at the other console with me. So I think the argument about 2 doctors in the room is nonsense because we've never done it that way.
Is that generalizable to the community? Because that's kind of what we're talking about right
I
now.
think it is, but I think it comes back to the system, and I totally agree with you that robotics is a team. I mean, VATS is a team sport too, but robotics more so, in that your bedside assistant needs a certain level of skill because they're putting the staple on the pulmonary artery whereas you are, and I do think that makes a difference. Does that translate to safety? It comes down to your team and how good your team is and how well they're trained. I don't think that the safety is any different, but I do think it
Well,
there's more of a team
let me just
approach.
interrupt and get other input. But so again, we're doing a lot of lung surgery at academic centers. What about the person who's doing 1 or 2 lobes a month? Isn't that who I think the argument is this more generalizable to the open surgeon or the guy who's having trouble with VATS than, is VATS or robotics easier than VATS? And the question is, if you're doing 1 or 2 a month, can you justify having a dedicated team, and do you get that comfort level?
I think you do more with the robot, but I want to hear, Bernie, what do you think? Because you've talked about this.
Yeah, I mean, I think that there is very real concerns about safety from the sense that the operating surgeon, the control surgeon, is not at the bedside. However, with that said, I agree with what's been said in the sense that I have also done several hundred cases that it requires safety requires anticipation and avoidance of injury. So you have to be prepared for that. The team has to have an action plan for that. There has to be a sponge stick on the table and a plan of what is going to happen if there is unexpected bleeding. I do think that using a robot is actually like driving a Mini Cooper. Some people say, well, why would you drive that car? You get in an accident and you're going to be crushed like a sardine. But the bottom line is people say when you drive that car, it handles so well that you avoid trouble. And I think robotics is like that. I think that
Mini Cooper, okay.
There was a lot of, there was mention about, robotics in terms of whether it's really necessary. That kind of that the loss of tactile sensation is a big thing. But to be honest, the visual feedback is so good that I almost feel like I can feel the tissue and how it's responding because I can see it in 3D, with binocular vision, which I think allows you to avoid trouble, to anticipate, and then even if you do get into some trouble, to stabilize what's going on so that you can then take care of the problem. So
And teaching, and the teaching point about the tactile feel, when I give my fellow a Harkins on a VATS lobe, I don't know what the hell he's feeling, but when the fellow's getting around the vein with a Cartier, he doesn't feel anything, neither do I, but we both see. So I think it's much safer to teach a robotic lobectomy than it is a VATS lobectomy because neither one of you can feel, but I see so much better. I'm sorry.
And I disagree with that.
I knew you would.
Because of just that sense, that tactile sense, but also, too, we're going through the process, the prevention of maneuvers. We know where we can, when we go around, we can pull more this way or push against the bronchus or vein and so forth. And I see it, too. I don't have binocular vision or whatever it is, but I can see I still do everything with a 0 scope.
And you can
So do
feel
I.
it, too.
And I
When
can
you've got
feel
a
it.
ring
Not
that
when
you're
it's
holding on the lung, when you're assisting that person going around, you can tell when they're pushing hard. You can feel it, you can see it, and you can intervene.
I can see it with the robot better than you can. So let me give you an example. When you're doing a right upper lobe, you have your assistant holding the lung, and you say, hey, you're pulling too hard. But it's not in your hand. How do you know? Visual cues. My visual cues are better. I got 3D 10 mag. So I submit to you that you can see the tension just as well as you can feel it. And I really believe that's true.
I think robotics is a different technique. It's not a VATS technique, and I found that when I tried to transition from VATS to robot, it didn't work very well. When I approached robot as a new technique and just started everything from 0, it worked much better. And so I think I think Bernie's made it, and he's done a good job going from VATS to robot with the same technique in a lot of ways.
Which is the rarity.
Right, but most people, I think, when they approach a robot, you have to approach as a new technique and learn new cues and new markers that will help you, get to where you want to go. And I think the pitfall is trying to fit a square peg in a round hole.
Do you really think, and I think you've made this point, sir, that you don't need VATS to go to robotics? I mean, isn't there some value in getting used to a 3-dimensional world in 2 dimensions moving small instruments around before you just go into the robotic world?
I think we're also biased by our own experience. We can't honestly answer that. You answered that question, but that's from your own experience. I've answered it from my own experience, which is also no good. And so I think from training a lot of people who've never even done VATS wedges for interstitial lung disease, can you imagine? They've transitioned unbelievably well from open to the robot, but they all failed VATS. And I mean, these aren't 5 or 10, these are 20, 25, 30 guys now. And so if you talk to them, and we have an abstract which got rejected at this meeting, like most of my abstracts, but about teaching robotics, that's a common thread. Do I have a p-value? No. So I think it does in some, but there's other problems, and that is if they don't have the volume, if they don't have the familiarity with the anatomy, which is what you're talking about with VATS. I think if they've done a huge number open and flip the lung back and forth and really know the anatomy the way you guys do, then maybe you can skip VATS. But I do think there's an advantage, to answer your question, to have done some VATS to go to the robot. But I don't think it's a necessary pathway to go that way.
But as we train fellows, excuse me, who most of those who had not even done an open lobectomy.
Just scary.
And then but they've had laparoscopic experience. So that's a little bit of advantage for them.
Good point.
So they can go and do from a VATS, and they've never done a robot before. So I think for us, as we're training more general surgery residents who are coming out earlier, I think that's the main advantage with them.
That's a good point. So maybe I'm saying they're doing so well going right to the robot, but they've had laparoscopic experience. That's what I mean. I may be missing that link. It's a great point.
But I guess the other question along those lines is, and as I've looked at it again, this curve seems a lot steeper than I remember the last time, or with VATS, and maybe it's because I'm demented and I don't remember 10 years ago. But it isn't. Just understanding how this device works, how to troubleshoot the device, how to get the angles right, how to get the ports right, how to get the tactile feedback. I don't think it's a 20 case learning curve. I think it's 30 to 50.
But the problem also is that, Scott, that you're an expert in VATS lobectomy, and you're literally an international expert. You've done so many thousands of cases that it's, to make that shift, I would almost argue it's unnecessary, actually. So robotics isn't something that is necessarily for Scott Swanson or Dan Miller or Rob McKenna or Tommy D'Amico, but is it something that is for the surgeon that is either soon out of their training or that is not yet set or have mastered a technique of VATS, or is it for somebody who wants to make that transition from thoracotomy surgery to minimally invasive surgery? And why not give them all the best tools? Why not give them the best vision, the best magnification, the best wristed instrumentation? So I think that's the difficulty, is that for a person like you that's mastered a certain technique, of course, to then try to, unlearn that or to some degree and learn a different technique I think is very difficult to do.
You have to. I'm trying to put my hat on as, educator and trying to lead young people, and I'm not sure, because I think that is a lot simpler. I'm trying to get the car analogy that might work here, but. It's a powerful machine that's simple to use, so there's less problems, and you know what you got. The robotics may have some advantages around the tactile around the 7 degrees of freedom and the optics, but you're getting a lot of extra stuff with that robotic computer that you might not have to have.
What is the big advantage of robotic versus what is the advantage?
I think there's
you bring up this lymph node thing.
I think the lymph nodes
and there's no data out there.
So you haven't been reading my literature. I don't read it either.
It's because you take your lymph nodes on the back table and you cut it up like Ginzu on the back table.
But and if you read this meeting, there's not one, not two, but 3 papers saying VATS lymph node. But you guys are all going to argue that, but it ain't just coming from me, brother. It's coming from other people, many other people.
But wouldn't you see a difference in survival?
No, absolutely
or local
not.
recurrence?
No, of course not, because the studies aren't powered to show that. You know that. You're a scientist.
But there's meta-analysis databases out there with tens of thousands of VATS lobectomies, and there's never been a higher local recurrence rate.
Oh, yes, there has. So that's where I disagree.
Wait.
That's where I disagree.
No. JCO, Australian meta-analysis by
that's one study.
John, and then Mattis's group. Another separate database.
That's another study.
Local recurrence was the same,
Because you
and
had-
actually systemic recurrence was less.
Why? Because you got T1A lesions that are being done with VATS, so they're not going to get a local
We can shoot
disease.
holes through it, but that's the data. So if
But what
there was
about
an
today's
inferior
data?
order,
What about the data being presented at this meeting?
I haven't seen it
Well,
yet.
you'll see it. It's coming out. Read the abstract.
So this is the first ever in 30 years. It's
No.
shown an inferiority of VATS.
No, there's been
local recurrence.
there's even been a couple papers that showed superior survival, which I don't believe, but you know, from Amsterdam and from Europe. So
With open?
No, with video-assisted
All right,
thoracoscopy.
but I'm saying there's never been a data that's shown VATS lobectomies have a higher local recurrence than open.
No, I agree with that.
So
but
if
the
lymph
studies
nodes
weren't
were an
powered to
issue,
do it.
If lymph nodes were an issue, you'd see a difference in local recurrence.
But none of but these
Okay.
are all
These are all
retrospective.
In my
Right.
experience,
Highly
in my
selective.
These are
experience,
highly
I haven't had local recurrence problems in the mediastinum or the high.
So let me go to the point I wanted to go to before, because the nodes we can argue all day. The other reason to do robotics is not just pulmonary resection, but mediastinal work. And I think there's a real superiority for that. And if I was a hospital owner, would I buy a robot just for thoracic surgeons, what you're saying? No. But since the GYN surgeons pretty much have to have it in urologic surgeons, and yet we can argue their data, but we don't know it, but there's a perceived advantage enough where that's how most prostatectomies and hysterectomies are done. Now the robot is there in the hospital. So the question is there a patient benefit for thymectomy and mediastinal work with the robot? And that's how I got interested, because I agree with you guys. I said, I'll never use this for lung surgery. Then I started doing mediastinal and said, my God, this is great. And then I saw the advantage, be it very level playing field. But what about thymectomies and mediastinal tumors? Do you think there's an advantage there?
I guess it all depends on your technique. You know, my VATS thymectomy technique, you know, I was pretty happy with. I got it pretty clear. And I don't think my robotic thymectomies are that much better than the VATS thymectomy, but I think it kind of depends on where you're coming from. You know, I mean, if you're comfortable doing advanced, then I don't think a robotic is going to add that much. If you're not comfortable with your VATS at all, then it may.
Bernie?
Yeah, I mean, I think that the statement that it depends where you're at and where you're coming from is entirely accurate. And again, we're talking about really all the data are coming from high volume, really world-class organizations. But the question is that where most of the surgeries are being done, where most of thoracic surgery and thoracic treatment is being done? And the answer, unfortunately, is no. I mean, the majority of this is being done by general surgeons or cardiothoracic surgeons that do both cardiac and thoracic surgery in the community. So the question is, if we want to achieve a benefit to our patients of getting more minimally invasive techniques, which we know are beneficial, what is the best platform to do that? I'm not arguing that robotics is the answer to that. Perhaps it's training, surgeons to be better at video-assisted techniques. But the bottom line is that the techniques have been around for 30 years, and yet, practically speaking, that's still not the standard approach for the majority of operations being done in the world. So the question has to be why.
Yeah, because for 20 years we had to argue that it was even a reasonable cancer. It wasn't until early 2000 that the powers that be said, you're right, it is a reasonable cancer operation. So then we could start training people.
And for us, it was easy when laparoscopic gallbladder, laparoscopic Nissen started out. It wasn't malignant disease.
Right.
It could be if you had a problem, it'd be like a malignant disease. But for us, when we took it to that next level, that was an oncologic principle that we had to go through years and years of for 20 years.
It's a great point.
But the number one thing, too, is to educate the patient. They have to know there are three approaches: open, VATS, and robotic. And then they, with the expertise of the surgeon, so if that surgeon doesn't do robotic or VATS, they should have the professionalism say, well, I can refer you to somewhere else to do that. And I think it's very, very important.
But now I want to make a point on that, because when you start reading websites that the robot is superior, there is no data for that. So I also want to caution and be very fair that, I'm happy to have someone do a robotic lobectomy for cancer. But I think it better be a guy who's really doing a great lymph node dissection. I still believe the nodes matter. I still think if you look at the data, getting more into lymph nodes increases your staging. Does that translate to survival? We can argue all day. We don't have a prospective study.
In your heart of hearts, it's hard for me to believe you really think that technology, VATS technology, limits the lymph node dissection. It doesn't. It just does not. You may not how to use it the right way.
You're
But
right.
if you know how to use it, there's nothing limiting about the lymph nodes using VATS or robotics.
So I want to defend you, and by saying, you look at the way most open surgery is done, the lymph nodes aren't good enough. And it has to do with the surgeon and the training as opposed to the technology. But I do think doing an excellent complete thoracic lymphadenectomy with VATS is more demanding than with the robot. Certainly you would agree with that.
You have to look at the different stations that are done. The big dilemmas for VATS is left,
7 on the left.
also AP, a window on that side. But then again, there's different techniques that we have learned, increasing tidal volume, 45-degree scope. But also, too, you all have different techniques for your 4R lymph nodes and different things like that. So it's all that learning curve to maximize your lymph node dissection. We can all do it. We can move the scope around if we have to and so forth. So it's the ways we educate to do that. So I think the lymph node thing is going to be a wash.
So let me just bring up, another issue is around, so I think efficacy, we're saying minimally invasive is what we need. We need to do minimally invasive, and I agree. And whether it's robotic or VATS, I think you got to look your hospital in the mirror and see what's the best thing in your community. But I believe VATS may ultimately be more generalizable, but closely connected in this day and age is the cost one. And I think even though you have a robot in your hospital, the cost per case, there is an incremental cost. It's $1,000 to $2,000 if you look at the data, and there's going to be a paper coming out using a database that shows that. And so maybe that gets lower over time, but that's a pretty big chunk of change.
So I think cost is a real issue, and I also think credentialing. And I wanted you to mention that because, you know, we need to credential teams, not surgeons. And when you do robotic surgery, it is a team sport, and we have to have safety for the patient first. And I think teams are not really being credentialed, and that's something that I would like to do, and Bernie is doing, where we really train teams as opposed to surgeons. And I think that's more important. I'm not putting the robot down. I think that's more important in robotic surgery than VATS surgery. Bernie, you've done papers on cost.
Yeah, you know, cost is a very complicated topic because it's easy to point at the robot, which is an expensive system. It's upwards of $2 million now to purchase the system. That doesn't even include the disposable cost per case, the $200,000 a year to maintain the system. But I think you have to regard that as a capital cost of that the hospital entertains. So currently in the United States, unlike in Europe and some other countries, we don't charge extra for the robot. But with that said, absolutely, every case there are disposable costs that make it more expensive than a VATS lobectomy. But really, I think the comparison is, what is the cost of saving a person a thoracotomy versus a minimally invasive approach? If robotics is the pathway to do that, then I think that the cost then starts to become less of an issue. And getting back to what was said about robotics in terms of the issues regarding whether it's the best and platform to make that transition, it's really difficult to say that. I think that it's not for everybody. I think if you're facile with VATS, that you should stay with that, and I would never argue to make that transition, because of the time investment and the cost investment. But these systems are being used by other specialties, and I think we have to face that in thoracic as well.
One last comment.
Yeah, and just one, and for me, it's the process. It is the team. It is a team sport. It's in there, but also thoracic surgery is a contact sport.
You got that.
So the tactile sense is very important. Also, cost is time in the OR. I could do 3 VATS lobectomies compared to 2
No,
VATS.
you can't. But I'm doing my robotic lobes in an hour and 40 minutes.
The day I was there with you, it took you 4 hours. Were you just teaching me that day?
Probably. Yeah, you were slow. I had to go slow for you.
All right.
I think that what we've heard today from this expert panel is the passion around minimally invasive lung surgery and other types of thoracic surgery. And the key thing is learning a way to do that. And whether VATS, which I think is tried and true, and we understand the outcomes well, and we understand the cost issues well, that to me is the best platform currently. But the robotic platform is new and evolving and clearly gives some people a leg up. And so the question is, learn the best way in your community, learn from the experts, and look at your data and make sure you're doing it safely. And the cost piece, I think we'll learn more about as time goes on. So I don't know if each member has a little wrap-up thought, or...
It looks like a presidential debate. Let's get a 1-minute wrap-up.
I think our goal is to provide the best outcome for patients. Clearly, minimally invasive does that. Which technique is best? I think robotics is still evolving. I think the current platform is not the end platform, and we'll know better once we go through several generations. But I think both certainly have their place in our field.
So I think the robotics, as Bernie said, is the more evolved, minimally invasive platform. And if you're going to hitch your wagon to one, you might as well hitch the one that I think has the brightest future. To me, with immunofluorescence, with Firefly, with being able to tag molecular cancer cells, be able to maybe use the robotic console to see those things, with some of the robotic staplers that are coming out, the 5mm Cardica staple and other things, I think the future is really bright for robotics. It's not the end all, I agree with you, but I think the future is bright. So I think the argument here today is minimally invasive surgery for stereotactic radiosurgery, and that we stage the patients better, we get the tissue out, we get molecular markers. When we do radiotherapy, we don't. We do a better staging, and we clear lymph nodes better. So to me, I don't care if it's VATS or robotics, but surgery I still think is better than SRS. That's my main point.
The most important thing is to individualize the patient. And I think it's very important, whatever that, the anatomy, the histology, the comorbidities, you have to be able to offer that to your patient. So that's why it's very important at an academic center, like we're all at, that you can tailor that to the best of its ability to do that. And that's what the patient deserves to do that. Right now, I think VATS is the minimally invasive way to go. But I agree with stereotactic is that I think that's going to fall off, you know, over the next couple of years, because we can deliver lower mortality, morbidity, and nodal involvement.
I agree 100% with that. I think that the 2 points that I would want people to really take away from is that minimally invasive surgery is what we should strive to provide for our patients when it's appropriate. That robotics is really the best iteration of that in terms of technology, but it needs to be applied selectively and appropriately. And I personally think that it will allow us to actually expand our indications for minimally invasive surgery. So instead of doing the simplest, earliest cases necessarily robotically versus VATS, that we could do more locally advanced cases, cases that require, that either are after chemotherapy or that require a chest wall resection, etc. Something that people can then use the technology to really expand what we offer to the patients rather than simply the early stage, quite straightforward case.